Next up, we have two presenters that will talk about sickle cell disease in females and males. So we have Leena Nahata from Nationwide Children's Hospital. Dr. Nahata is a board-certified pediatric endocrinologist, associate professor of clinical pediatrics at The Ohio State University College of Medicine, and is the founder of the medical director of Fertility and Reproductive Health Program at Nationwide Children's.
All right, thank you so much. So I feel like this afternoon session is like we might as well put a big question mark up here because it's all the populations where they're so little known. So it is my pleasure today to be talking about fertility considerations in individuals with testes and sickle cell disease. And we're going to start with a case. This is the case of Alex. He's a 15-year-old male with sickle cell disease. He's been treated with hydroxyurea for 6 years. He actually undergoes fertility testing during a research study, which finds him to be azoospermic. So he says to his pediatric hematologist, what does this mean? What should I do? I really want to have kids. Should I stop my medication? And if so, how long should I stop it? And so you can imagine this creates a lot of nervousness. And the pediatric hematologist says to him, well, this was just in the course of a research study, so we don't know all these answers, but this does not make him feel any better. So in that context, the objectives for today's talk are to talk about what's known about infertility and fertility impairment in men with sickle cell disease, to talk about whether genetic parenthood is important to this population, so getting the patient and family's perspectives, and then starting to understand how reproductive health is actually integrated into sickle cell disease care for this population. So in terms of disclosures, I have funding from the National Cancer Institute and then also the Ohio State University Center for Clinical and Translational Science. From a terminology standpoint, we're going to use the words men and males to refer to people born with testicles. So just briefly, for background, sickle cell disease is an inherited blood disorder with 2 abnormal beta globin genes. We know that it leads to hemoglobin polymerization, abnormal red cell shape, impaired blood flow, and hemolysis and anemia. And really, there's a multitude of comorbidities and end organ damage that occurs in this condition with frequent pain crises. So there's approximately 100,000 individuals with sickle cell disease living in the United States. And it's really important to note that most of these are from racial minorities, and they face a variety of health disparities and have problems with accessing care in general. Fortunately, treatment advances have resulted in 93% surviving into adulthood. So just like we've done with cancer, we need to shift our focus not just to think about survival, but also to think of late effects of both the disease and its treatments. So in terms of the curative treatment, it is bone marrow transplant. A minority of these individuals will go on to transplant. But there are a variety of disease-modifying therapies, and the most common one we talk about now is hydroxyurea. So hydroxyurea reduces morbidity and improves quality of life for this population, and guidelines really are encouraging early treatment as early as 9 months of age and shared decision-making in this context. Well, when you look at the studies of men with sickle cell disease, 90% have abnormal semen parameters, so it's really strikingly high. What we don't know is how much of that is the effect of the disease, which can cause chronic anemia, testicular infarction, hypogonadism, and priapism, and how much of it is a result of the treatments, including bone marrow transplant and hydroxyurea. So with regard to transplant, it's really difficult to differentiate the effects of the disease, potentially hydroxyurea that's given early in life, and then the actual transplant. Number one, we're not routinely doing pre-BMT semen samples. And when we do them, we see that many of them are abnormal, so we don't know how to parse out what the different effects are. Large studies examining semen parameters have not been conducted in this population post-bone marrow transplant, and we know cases of fertility have been reported, but at the same point, there are a lot of data showing abnormal parameters in many of these individuals after transplant, even in some that have received reduced intensity regimens. So at this point, it is recommended that we should offer sperm cryopreservation, which we know is established and effective prior to transplant, and that even testicular tissue cryopreservation, which is experimental, should be recommended prior to bone marrow transplant. And so far, according to Kyle and his group, they have done 88 cases of youth with sickle cell disease prior to transplant. All right, so what do we know about hydroxyurea? And we'll talk about semen parameters first. So this was a study published 6 years ago, 35 men, 18 to 60 years of age. The investigators collected semen samples at baseline and then 6 months after starting hydroxyurea. So what you'll see here is that the semen parameters were abnormal at baseline, and then within 6 months, across the board, the parameters were far worse. So really striking data, even though it was a small sample. However, subsequently, the study was published, 26 samples from 15 patients treated with hydroxyurea with a median duration of half a year to 10 years versus 46 samples from 23 naive patients and did not find statistically significant differences. However, both groups had abnormal parameters, and they also gave the caveat that many of these that were on hydroxyurea were also on transfusion therapy. Well, this was a mouse study, and these investigators found that all indices of fertility were significantly reduced among mice treated with hydroxyurea compared to controls, but they did see improvement after a 4-month withdrawal off of hydroxyurea, even though when they did a mating experiment, it still was not, they did not get the same results as they did in the control mice. Okay, so what about the spermatogonial pool? So this was a study done of about 100 youth across Amsterdam and Brussels, and they found that the lowest population of the spermatogonial quantity was in people with brain tumors and then hematologic conditions, so sickle cell disease, both treated with hydroxyurea and not treated with hydroxyurea. So again, doesn't really tease out the effect of the drug, but it just tells you this population has a low pool. This study, again, found a low pool. This was 30 individuals, and they looked at 17 who were on hydroxyurea versus 13 that were not, and the median age of hydroxyurea was 5, and they did not find any significant difference, but again, found a low pool. And then finally, in 29 boys with sickle cell disease who had undergone bone marrow, TTC prior to bone marrow transplant, most had lower pools of spermatogonia than reference ranges. Interestingly, younger age and earlier age at hydroxyurea initiation were correlated with lower numbers of cells. So this is what makes it really hard. So on one hand, we say, let's get them in. Like I want to call Kyle and say, hey, can I send you these patients to do TTC? But when should we even be considering, to do that? What is the right time? We just don't know. And then finally, what we really want to know is how do all these concerning numbers actually translate to fertility outcomes? So this was a registry study published just this year, looking at a large group of females and males with sickle cell disease in a consortium, 884 males, and 16.9%, so almost 17%, reported infertility. But the number who actually tried to conceive was not assessed. And it's important to realize that 77% were unmarried and 55% were only 18 to 29 years of age. So it makes me a little nervous to quote the 17% because we don't really know what the denominator was. So as you can see, when it comes to these questions, we really do have more questions than answers. So when it comes to risk, how can we distinguish the impacts of the disease versus treatment? If there are effects of hydroxyurea, are those transient? Does the dose, duration, and age at initiation matter? What is the actual risk of infertility in men with sickle cell disease? So we really need larger longitudinal studies where we're getting multiple samples over time to start to understand this. And then when it comes to interventions, should sperm banking be considered, and if so, when, outside of the transplant situation? Is it safe to stop hydroxyurea to bank in adolescents? When should we consider testicular tissue cryopreservation? And then, of course, how would the cost of any of these things be covered? So just keep in mind, Alex, from the beginning, when he's asking you these questions, we don't really have the answers. So it makes it really hard for us to know how to guide them. And there really are no guidelines in this condition. So now, in that context, let's think about, well, is genetic parenthood important to this population? And are we doing a good job informing this population of these potential risks? So this was a retrospective 2-site chart review done at Nationwide Children's and NYU. The age range was 14 to 21 years of age, and it was about half female, half male. 4% had documented fertility counseling across both sites. A little over half had documented contraception counseling, and a little over half of sexually active individuals reported using birth control. So you can clearly see the fertility counseling was really low, and there are also other gaps when it comes to reproductive health care. So to follow this up, we actually did a pilot study to examine fertility testing knowledge and attitudes in male adolescents and young adults with sickle cell disease and their caregivers at our site. So just to understand, if we are gonna start to conduct these large and longitudinal studies, getting fertility testing in this population, are they even aware of this issue, and are they gonna be willing to do it? So this is 20 adolescents and young adults, so high recruitment rate, 91%, and 15 caregivers. The vast majority said they wanted to have a biological child in the future, so really similar to what we see in the cancer population. However, their knowledge about this topic was really low, so only about a half said that they had received any information about fertility from their provider. Less than 25% of the kids said that they knew that sickle cell disease could impact their future fertility, and only about 10% or less knew that their treatments could impact future fertility. So then we asked, well, if you were told that it might be difficult for you or your son to have a biological child in the future, would you be interested in having you or your son's semen tested? And if so, why or why not? So what you see here for the adolescents and young adults, 43% said they would be interested. 50% said they weren't sure, they really didn't know anything about it. The caregivers were more hesitant. About half the caregivers said, I don't know, he seems really young. And again, they hadn't really heard about this topic from their providers, so they didn't have a lot of context. So this to us felt like a major gap, and we were fortunate to receive some internal funding to develop a program called Fertility Education to Understand Reproductive Health and Sickle Cell Disease, or FUTURES. This is a web-based education program, and it was actually developed with a community advisory board, so 3 male adolescents and young adults with sickle cell disease and 2 caregivers, and a digital design team, and we also got some input from a health literacy expert. So this is some example slides of what FUTURES looks like. So we wanted to express the fact that sickle cell disease may impact fertility, that the treatments may impact fertility. Regardless of that, they should still use contraception, that this is an inheritable disease, so that if they wanted to know if their child could have sickle cell disease, their partner would need to get a blood test. And then finally, if they were interested in learning more about their fertility, what a semen analysis would entail. We had some key interactive elements across the modules where we had, things you could click, and then they would define what they were, and then some intermittent knowledge checks throughout the modules. And then we pilot tested it. So this was a single site study. We recruited 14 to 22-year-old males with sickle cell disease and their caregivers that were primarily English speaking. We did a pre-program knowledge survey, administered the program, and then assessed their knowledge afterwards. And then we offered them fertility testing. So anyone that participated in the program could get a fertility test in collaboration with our local off-site testing center. And then finally, we explored factors influencing testing decisions. So we did find that at least administration of the program was relatively feasible and acceptable, and we recruited individuals in clinic, on the inpatient unit, and also remotely, with a 73% recruitment rate. And generally, both the adolescents and young adults and their caregivers were satisfied with both the content and the format of the program. In terms of efficacy, our mean knowledge scores, at least in the short term, did increase in both the adolescents and young adults and the caregivers. You can see in both groups the knowledge went up. However, only 15% pursued testing. So even though they'd all completed the program, they expressed interest in this topic, and we explained to them how fertility testing would be done, very few of them did it. You can see here the age ranges of those who did it were anywhere from 15 to 22. 3 of the individuals had never used hydroxyurea, and none of them had actually had a transplant. That was part of our exclusion criteria. And then 2 of them had been on hydroxyurea, one of them for over 5 years and one of them for over 10 years. And then, as expected, from what we've seen in the literature, there were abnormal parameters in all 5. Some of them had many abnormal parameters, and some of them just had 1 abnormal parameter. Some with highly abnormal parameters had never used hydroxyurea. So then when we asked about factors influencing testing decisions, those who did get the testing said they were interested in learning more about their reproductive health, and they appreciated the assistance coordinating their appointments and covering the cost of testing. They said that made it easier. Whereas those who didn't get tested cited lack of time, lack of transportation, and then discomfort with the procedure. So in summary, we see that data are emerging on the reproductive health implications of sickle cell disease, with definite concerns about potential impacts on male fertility. However, awareness in this population remains limited and counseling practices are inconsistent, and it's really imperative to develop accessible educational materials for this population, and we feel that community engagement can at least help promote efficacy and acceptability. In terms of next steps with this program, future research will examine the feasibility, acceptability, and efficacy in a larger population across a variety of settings. And then we really need to assess the feasibility of innovative approaches to fertility testing, like mail-in testing, because of the barriers that this population faces. Ultimately, we want to test this in an effectiveness implementation trial, because this type of tool really needs to be integrated into clinical practice in order to really increase knowledge and awareness in this population. And then just as we wrap up, I think it's really important to address the disparities that we see in this population. So we definitely need evidence-based guidelines to optimize reproductive health care, fertility, contraception, genetic transmission in this population. And as I often say in the trans population, when I compare what's known in that population to what's known in cancer, it's a stark difference, and it's no different here. So 20,000 hits on PubMed when you look up cancer and fertility, 200 when you look up sickle cell disease and fertility. And there are significant research funding disparities. So it has been clearly shown that chronic conditions affecting Caucasian populations, like cystic fibrosis, have received much more funding than sickle cell disease has. And so how do we actually conduct the research? We need advocacy efforts for fertility preservation coverage, and then ultimately, we need decision tools to help facilitate discussions and decisions about sickle cell disease treatments and fertility preservation. So ultimately, currently I'm working on a decision tool in cancer for male adolescents and young adults, and we have seen some promising data at our site, and the goal is now to adapt it and implement it more widely. And so hopefully we can use a tool like this to be able to help individuals with sickle cell disease once we figure out what, as providers, we actually want to tell them. And then, as we see, the landscape continues to evolve. There are new treatments on the horizon, and we're going to have to navigate this whole situation as we figure out what's happening with these treatments. So, in close, I just want to thank the planning committee for inviting me, my scientific and clinical collaborators, my fertility and reproductive health collaborators at Nationwide, our research staff, community partners, the design team, and our funders. Are we taking questions now or at the end?
At the end.
Okay, so thank you so much.
So now I welcome Jacqueline Maher from the NICHD. She is a reproductive endocrinology and infertility specialist, as well as a pediatric adolescent gynecologist. She is the director of the Female Fertility Preservation Program at Children's National Hospital and co-chair of the Oncofertility Consortium's Non-Oncological Subcommittee. Welcome.
Thank you so much, and thank you everybody for sticking around this afternoon. Thank you to the Oncofertility Consortium for inviting me. I have the pleasure of speaking about fertility preservation in people with ovaries and sickle cell disease. I have no disclosures. So the learning objectives for my talk are to explain the pathophysiology of sickle cell disease briefly and current treatments, to describe the fertility preservation options available and what those outcomes are in this population, how to minimize complications by using a multidisciplinary approach, and review challenges, insurance coverage, financial barriers, and some solutions for this population. So similarly, I'm starting with a patient named Mary. She's an 18-year-old with sickle cell disease. She's had sickle cell crises, chronic pain, acute chest syndrome, asthma. She's had a cholecystectomy, a splenectomy, and is taking hydroxyurea, Flovent, albuterol, and hydromorphone chronically. Like Dr. Nahata has discussed, it's a group of inherited hemoglobinopathies. There are 20 million people worldwide affected with sickle cell disease, and 100,000 of them are here in America. It results in end organ damage throughout the body, but what's often not addressed is the reproductive system. But we need to keep in mind that the placenta, the uterus, and the ovaries are all end organs as well. As we've gone over many times during this symposium, women are born with a set number of eggs that declines over time till the average age of 51, the average age of menopause. And from our cancer populations, we know chemotherapy, radiation, bone marrow transplant will drastically reduce the ovarian reserve. What we know less about is vaso-occlusive crises and hydroxyurea and what that does to the ovaries. The spectrum of ovarian function goes from normal ovarian function to subfertility and infertility. We use markers of ovarian reserve, FSH, AMH, and antral follicle count to help define diminished ovarian reserve, or DOR, and ultimately this can result for some of the population in POI. What's important to note is these women have a shorter reproductive lifespan. They have delayed menarche by about a year, the average age being 13. And they have an earlier menopause noted in Brazil, who has a similar age of menopause as the US at 51, and their age of menopause is reduced by 5 years. Studies that have been coming out more recently have shown that they have a lower ovarian reserve and a faster rate of decline with lower AMHs and worse oocyte cryopreservation outcomes. So why does this occur? The hypotheses include vascular damage to due to small vessel occlusion to the ovaries, chronic transfusion and iron deposition, and treatments including hydroxyurea. So looking histologically, the follicle density in patients with sickle cell disease, this small study looked at focusing on 4 patients with sickle cell disease, found that there was no difference in the density of primordial follicles, morphology, or expression of follicle and oocyte-specific proteins compared to their age-matched reference group. And you can see linearly the gray circles being the controls and the blue diamonds being the sickle cell patients. So we have done a similar study at NICHD with the Oncofertility ovarian digital slide database that Dr. Gomez-Lobo was talking about earlier. This now houses about 2,500 slides from 420 patients. And so when we looked at our patients with sickle cell compared to those that were controls, quote unquote controls that had cancer and other diseases, we did find that they had a mean follicular density with a faster rate of decline in the earlier ages up until age 16, which was our cohort. To try and better understand what that meant during this time period as a representative of pubertal status, we looked at 0 to 8, 8 to 13, and 13 to 16, and we found a significant difference in comparison to the controls that did not have a difference over age, like a slow decline, but more drastically from 0 to 8 to 13 to 16 in the girls with sickle cell. Histologically, you can see that those that are 5 years old, the controls, the follicles reside along the cortex, and those that are 5 years old are similar between sickle cell and control, or when they got to the older ages in their teenage years, the controls had still a number of follicles in the cortex, and there were very few in those with sickle cell disease. And these are all OTC patients prior to their bone marrow transplant. We then compared their follicle density to their AMH levels, and we found that there was no correlation, which was quite interesting. Again, maybe representing that AMH isn't the greatest marker of ovarian reserve in the younger girls. To further understand the pathophysiology of why this may happen, we looked at the vasculature and we stained the ovarian tissue with P-selectin, which is a marker of inflammation. And you can see that, it stains much more intensely in those with sickle cell compared to controls, which did not have had very little P-selectin staining. To evaluate iron deposition in the ovary, we stained the tissue with Prussian blue, and you can see iron deposition we had in 3 of our patients compared to 0 in the controls. So this led us to believe, that it's possible that it's both the pathophysiology of the disease itself, as well as possible treatments. So the treatments include transfusion, red cell exchange, hydroxyurea, hematopoietic stem cell transplant, and gene therapy. In the interest of time, I'm going to go over the data of these 2. So hydroxyurea, like Dr. Nahata has discussed, is a chemotherapeutic agent that was approved in 1998. It's given as early as 9 months of age and has drastically improved the lives of these women, these people. It decreases sickle cell-specific complications, pain crises, hospitalizations, and transfusions. The effects in the ovary are less well known, but it is contraindicated in pregnancy and often discontinued when a woman desires pregnancy. This nice study by Pecker and Christensen et al. Looked at, this is a combination of those treated with hydroxyurea and those without, and their AMH levels. And the dark lines represent the age-matched controls and their AMH levels, and you can see that there's a marked decrease in the AMH levels for those with sickle cell. Starting as early as 25, they're already reaching this diminished ovarian reserve marker that we use in combination with FSH and AFC of 1.1. And so from an early age, they already are having a decreased follicular, or a decreased ovarian reserve. When they then separated it into hydroxyurea versus without hydroxyurea, it was even more drastically reduced. So returning to Mary, because of her multiple comorbidities that have occurred, her team has now recommended a bone marrow transplant. The CED, or cyclophosphamide equivalent dose that was calculated, was 18.75 grams per meter squared. And stem cell transplant is currently the only cure for sickle cell disease. It's becoming increasingly available to these patients, but is very gonatotoxic. There are different conditioning regimens that are being offered or are given to the patients before the transplant, but in general, it results in infertility and POI in about 80%. Those with a successful pregnancy are very low at 0.6 to 1.3%. So Dr. Meacham, Dr. George, and her group also looked at these AMH levels before and after transplant, and found that 2 years after transplant, which is a good amount of time for the AMH to recover, 88% of them had an undetectable AMH, and 12% had an AMH in the diminished ovarian reserve range. And they found no apparent differences depending on the conditioning regimen. So we're all very familiar with the Pediatric Initiative Network coming out in 2020 with this female risk stratification, and to focus on cyclophosphamide equivalent dose, and it's split into prepubertal and pubertal, with prepubertal girls being able to tolerate a higher level. The hematopoietic stem cell transplants, regardless, are in this highest risk category. So Meacham and her group then looked at the different conditioning regimens, and now there's different groups. Some are considered myeloablative, others are considered reduced intensity conditioning, which is RIC. And when they looked at the actual CED levels, though this one had a lower CED of 5.6, these two, which are technically reduced intensity, which may be reduced for the bone marrow, actually have the highest CED and may be very damaging as well. So the future of treatments includes gene therapy, which has been coming out a lot in the news. But to look at that more closely, it includes CRISPR-Cas9 replacing the defective beta-globin gene with a repaired version of it. But the most important thing is, even if this is the cure, it still requires a bone marrow transplant. It still requires these gonatotoxic conditioning regimens. And until we have conditioning regimens that are less toxic to the ovaries, we're still going to be in the same boat. So the options that are available for people with ovaries include egg and embryo freezing, as well as tissue, cryopreservation, and transplantation. For Mary, what she decided to do, after counseling together, decided to do egg freezing. She went through one stimulation and successfully froze 13 oocytes. But afterwards, she then said that she wanted additional fertility preservation. She wants 5 children, and she wants to do more. So with shared decision-making with the teams, it was then decided to do ovarian tissue cryopreservation during her BMT admission, or right before her conditioning, so it would cover the costs, and she also has 13 strips cryopreserved for herself. I recognize this is not the norm, but we were happy to be able to do both of these for this patient. In a review of the literature, which got me interested in this patient population in the beginning, I worked as an REI fellow with Dr. Pecker and Dr. Christensen, and so we did a review of the literature back then, and up to now, still there's only 3 case series and 3 case reports that are specifically looking at this population. There are probably more outcomes that are intermixed as hemoglobinopathies, but to tease out sickle cell disease, these studies show that the number of oocytes retrieved range from 1 to 30, and the mean or median for the case series were 10.7 to 12.8. So we really need to work together to try and get more of this granular data to understand these outcomes. For OTC and OTT, there are 93 OTCs reported in the literature. Again, probably more than that are intermixed and considered other or hemoglobinopathies with beta thalassemia. We at Children's National, Dr. Gomez-Lobo and I have done 14, and that represents 21% of our OTC. So it's a big portion of our patient population, and though those are the ones that chose to, even larger portion of the patients that I counsel. Up to date here at UPMC, Dr. Orwood has said that there's 33 patients with tissue with sickle cell here. For OTTs, there have been 5. There are 4 live births, 2 from 1 patient, and 2 where there's no pregnancy yet reported. I'd like to focus, though, on this one by Dr. Demestri, that this is one of the only ones that is frozen tissue, even in the oncology population, where the tissue is frozen in a prepubertal or peripubertal state and then transplanted way later on as an adult. A lot of our data for patients who were postpubertal when they froze their tissue. So this is really exciting, and I think, again, we need more data, since there are very few with sickle cell disease who have gone through this. So the risk and complications. What is special about this population is that both of the OTC and the egg retrieval can increase the risk of pain crises, ovarian hyperstimulation syndrome resulting in complications, and the inciting incident at Johns Hopkins was a patient who had acute chest syndrome and respiratory failure. And so with that, looking at their baseline risk, they have higher risk of thrombosis, pulmonary disease, kidney disease, pain, infection because they've had a splenectomy. So specific to the fertility preservation, they can have pain crises during the stimulation. They can have OHSS that, if severe, will lead to AKI and DVT, so that makes things worse for them. General anesthesia can result in atelectasis. Glucocorticoids, which is an antiemetic that's often given, also can trigger pain crises. And so we really want to prevent ACS, multi-organ failure, and death due to surgery in general. Surgery can cause stress on the body, a temperature change in the OR, infection, as with any procedure. All of these can elicit pain crises as well. So how can we do this safely and try to prevent these occurrences? So we came up with a algorithm and a multidisciplinary approach that includes care between REI, PAG, heme, the bone marrow transplant team, and anesthesia. And so first off, it's important to note what genotype they have, and then work with hematology to decide if they need red cell exchange or a transfusion before the stimulation or before the OTC. Determine if they need an anticoagulation plan and what that will be. And then watch them during the stimulation very closely for both the retrieval and the OTC to give them a lot of hydration, preferably warm hydration, to prevent the crises, and then prolonged monitoring in the PACU and incentive spirometry to try and decrease acute chest. Special considerations for oocyte cryo, as with any patient, includes picking the right protocol for the patient based on their age, their AFC, their AMH, to maximize the number of oocytes and minimize that risk of OHSS, using Lupron as the trigger, doing DVT prophylaxis, so for example, giving enoxaparin starting 1 day prior to the stim, giving it till the day of trigger, and then holding it until postoperative day 1. Pre-op care, besides the IV hydration, is putting it as the first case of the day so they can be in PACU as long as possible and watching them for longer periods of time. Post-operatively, avoiding those glucocorticoids that can trigger the pain crises, and good pain control. And there's no consensus about the hydroxyurea. How long should it be held prior to the stimulation? And some centers are holding it for 3 months prior. So when and which? We all know best to do before the bone marrow transplant. If the patient comes to you after the bone marrow transplant with regular cycles but decreased ovarian reserve, try to freeze eggs or tissue at that time. And if they haven't gone to bone marrow transplant, or there's no time, that's not part of their plan yet, checking their ovarian reserve and seeing if they have DOR. Choosing between oocyte, tissue, or both is up for constant discussion, as we discussed earlier. And then briefly, the challenges for these patients are similar, but more than the patients with cancer. Though there are 17 state mandates for fertility preservation, 3 of them only cover cancer. Of those state mandates, many of them don't cover Medicaid patients, which is a majority of patients with sickle cell disease. Livestrong, that covers the IVF medications, doesn't apply to sickle cell. As our medical student discussed earlier, they have difficulty paying for storage fees. And ultimately, when they want to get pregnant later with the eggs or the tissue and need to do IVF, none of that is covered by the insurance either. If you're not aware yet and you're taking care of this population, there is a grant that's relatively new. It's been around for about 1.5 years, part of Be the Match and SC Red, and to date has helped 20 patients, both patients with testes and with ovaries, and it covers up to $10,000 per patient. The caveat is that the patient needs to apply prior to the bone marrow transplant, and it's a provider that needs to submit the form, not the patient themselves. For long-term storage, ReproTech, which is where a lot of tissue is held, they have multi-year reduced rates. And then also, many are aware of Verna's Purse, but there's also Anna's Gift. And Anna's Gift is income-based, but helps support patients that are non-cancer diagnoses. So there are many gaps in knowledge that we need to learn more about, including the pathophysiology of why patients with ovaries have decreased fertility just due to the disease, and better understanding the risks of infertility with hydroxyurea and the different bone marrow transplant conditioning regimens. We need to work together to get more oocyte cryopreservation outcomes on these patients, as well as live birth rates from OTC and OTT. And my take-home messages are to keep in mind that this patient population, they have a decreased fertility window at baseline. The treatments and those cures may further damage the ovary, and the fertility preservation procedures can increase the risk of their sickle cell complications. So a multidisciplinary approach to plan a safe stimulation retrieval, or OTC, is really important. We need to spread the knowledge about fertility in this population with patient education and offering them consultations, and to advocate for this patient population and their disparities. So only by working together can we reach the ultimate goal of insurance coverage for future embryo transfer and OTT, so that patients like Mary can use her 13 oocytes or her 13 strips of tissue and get those 5 kids that she desires, or at least one of them. I'd like to thank all those that I work with at the NIH and Children's National, the lab staff, our fellows and students, and my collaborators in sickle cell disease. Thank you. No.
No.
Do I have to turn it on? Now, can you hear me? Yeah. Lillian Meacham, Atlanta. Thank you both. Those were beautiful reviews of the literature. My question has to do with, should it be a standard that we do this washout of hydroxyurea before we bank sperm, before we take tissue, before we look at eggs? But we try not to bank on chemotherapy. Hydroxyurea is chemotherapy, and a lot of these effects are thought to be reversible. So why not give these kids the best shot and plan? And usually you have a long time from consideration of fertility preservation to BMT. So I would say maybe a place to start is really working with hematologists for a clear washout time. Thoughts?
But I think in the males, Lillian, I think that would make sense. We've talked to some adult colleagues, and it does seem like that's what they do, is that they stop hydroxyurea for at least 3 months. Some of the adult colleagues we've talked to, I don't think it's standard, I don't think it's out there, but that's what they've been doing. But I think the real question is, you're talking about sperm banking just before transplant as a scenario, not at any other time point? Yeah, so that's what we've learned from our adult colleagues, but I agree, I think that there needs to be more guidelines on this. But Jackie, do you want to talk from the female perspective? Or?
Yeah, I mean, ideally that would be the best thing to do, but I think it also, like working with the hematologist, it's important to know what their comorbidities are on that spectrum. You know, some have a lot of comorbidities and some don't have as many, and we don't want to put them at risk for causing an acute chest syndrome. So I think working together to decide who to do that on is very important. But if you can, I think that would be ideal. For the tissue, I'm not sure it matters as much, but for the egg retrieval, yeah.
Thank you. I learned a lot from that. I don't pretend to know anything about sickle cell, and I really learned a lot from your lecture. But I'm just wondering, as I'm hearing about this whole 3 days, is the biggest danger to them the hyperstimulation or just the surgery to remove the ovary? And it seems like hyperstimulation syndrome might be the biggest risk, and we could just remove the ovary with a mini-lap or a laparoscopy and also gain just as many oocytes from IVM and then avoid hyperstimulation. I don't know. It seems we'd avoid at least the hyperstimulation. And
I agree, but I think that goes back to the debate of which is best for which patient.
Yeah.
And since
Thanks.
more centers can do egg retrievals, then that might be the only option for some of those patients. But if they can do the tissue, then tissue is great.
We'll take one more question for this session.
Okay, so my question piggybacks after Dr. Meacham's question. It seems like there is no standard of washout periods. I know many hospitals do 3 months prior to sperm banking of washout of hydroxyurea before transplant. Our concern is that if patients, that subset of patients that can't do a washout and they're banking on hydroxyurea despite the warning and knowing what they're getting into, is that sperm going to be used later? Are they going to pay for years of storage and then show up 10 years later to an REI and say, I have sperm that I banked 10 years ago, I was on hydroxyurea, I want to use it with my female partner? And our concern is that they're going to say, I don't recommend using this, and it was all for naught. So for the REIs in the room, if a couple presented to you and wanted to use sperm that had seen hydroxyurea with no washout period, what would you do?
I think there's obviously an unknown, which is the theme for this as an REI, but I think it would be that shared decision-making model versus, if there is if he doesn't have any sperm to give at that time, using a donor versus using this. And I think potentially I would use, social support, like social worker or a psychologist that specializes in this discussion, also to look at, thoughts and feelings on, third-party reproduction.
I also just wonder what that sperm sample would look like on hydroxyurea and whether it would, potentially be a moot point. I feel like, these studies that have come out are just showing such poor semen parameters from the disease itself, and then if you're still on hydroxyurea. But I think your point is great, like assuming there is sperm to save the quality of that sperm, and definitely I think we would need to counsel on that on the front end so people didn't feel like they just spent, 10 years of storage fees just to be told that it wouldn't be useful.
Okay, thank you.
I mean, if they can give more than one donation, you can have a portion of that for the semen analysis, and I think the transparency of telling the patient how good or bad that semen analysis was is important as well, so that they know in the future, like what, like they're not surprised later on, like, oh, it's not the greatest sample.
Right, but even if they have a good sample, it's the integrity of the sperm
Yeah.
is what I'm concerned
Right.
about, the safety of using it.
Right, just like we talk about in the cancer setting when we're banking post-treatment
Exactly,
exposure.
yeah.
Yeah, no, I think it's a great point.
Thank you both so much.